Please note that we are recording these sessions for later distribution. Please know that anything listed in the chat does not appear in the recording. My name is Shreya Prasanna and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat function. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. To all the BWell Texas providers, please make sure that you identify yourselves during the session. Or if you're joining via phone, please email your phone number and name to bwelltx@utisca.edu. Some housekeeping, please stay muted unless you're speaking. If you join by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6. We also encourage you to unmute and speak, especially during the discussion portion of our session. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. Or if you prefer, you can use the chat feature to share comments and questions. Please note that no protected health information is allowed in either the chat or the discussions. Towards the end of the session, the Shout Texas Echo team will send out an evaluation survey. All participants filling out the survey will be entered into a raffle for a $30 gift card. This will help us get additional valuable feedback from you about how we can improve these sessions. Our didactic today is on pharmacology of medications for opioid use disorder, presented by Dr. John Weems. Following that, we will discuss a case presented by Dr. Daniel Handayan. We will start with introductions, followed by didactics, BWell program announcements, case presentation, and open discussion. Thank you again for joining us at today's Echo. In the spirit of all teach, all learn, we encourage you all to share your experiences, questions, and insights in today's conversation. With that, we'll do some introductions. Dr. Ramesh.
Hi, everyone. I'm Dr. Ramesh. I'm one of the hospitalists over at Dell Medical Center. Excited to be here today.
Thank you so much for joining us, Dr. Weems.
Hi, I'm John Weems. I'm an internal medicine doc and addiction medicine specialist here at Community Care. Texas is big at you and faculty at Dell with Dr. Ramesh.
Thank you so much for joining us. Dr. Lindsay.
Adrienne Lindsay, Director for the Center for Substance Use Training and Telementoring here at BWell Texas. Thanks.
Thank you. Alana?
Good afternoon, everyone. My name is Alana Bolton. I'm a program manager at Dell Medical School at the University of Texas at Austin, and I am the director of Shout Texas. Thanks so much for being here today.
Thank you so much for joining. And Dr. Handayan?
My name is Daniel Handayan. I'm a fellow at Baptist Memorial Health System here in Memphis, Tennessee. I'm glad to be here.
Thank you so much for joining us. With that, we will get started with our didactics. Dr. Weems, whenever you're ready.
Perfect. Thank you so much. So can somebody let me know if they can see my screen?
Yes, we can.
Sweet. All right. So first and foremost, good afternoon to all the Houston Astros fans out there. Congratulations. It's high times, gang. If there are any Yankees fans or baseball conspiracy theorists, please make sure you're muted and stay muted. Nobody wants to hear about it. But if you're an Astros fan, unmute and cheer at any time. Or if you have any questions along the way, please chime in on the chat or unmute. We're going to talk about medications today. These are some disclosures, none are mine, but some of the team members have some. So the learning objectives are first to understand the mechanism of action for our 3 FDA-approved meds for opioid use disorder, methadone, buprenorphine, and extended release naltrexone, which also goes by the trade name Vivitrol. We're going to recognize evidence for these medications. And then finally, I hope that folks leave able to formulate a process for making shared decisions about starting these 3 meds with our patients. A recent national study identified just how bad we are at getting these meds rolled out. And it showed that 6% of treatment programs, inpatient and outpatient, have access to all three of these medicines. And so what that means is when we're trying to navigate our patients, it takes a lot of work to get people plugged into the medicine that might save their life. So there's a lot of work to be done systems-wise, but I'm saying that to all say the goal of this is for a whole interprofessional team to have familiarity with these medications, to know how to support people during certain challenging phases of treatment, and to just have an idea of the kinds of considerations our patients are going to be making when they're thinking about which medication is best for them. So that's the goal. What this is not is sort of like a how-to prescribing guide for prescribing clinicians. If you do want that, the textbook length resource maintained by SAMHSA is Tip 63, which is available online. PCSS is a fantastic resource. The ASAM treatment guidelines are very helpful and available on the website, and so too the last reference there is a policy statement, how to think about equity when creating systems for opioid use disorder treatment, which is very important for reasons we'll talk about. This is from a recent review in the New England Journal of Medicine for evidence-based treatment of opioid use disorder. And I really like it because it gives you like the 4 buckets of what we're talking about when we're talking about treatment. And I think an ideal system would have all 4 of these components of all 4 of these buckets available to anybody as a menu of options when they're ready to engage with those. And what we're talking about today is in the second quadrant. So if you're looking at your upper left hand, is medications. And the first line there, that medication is a cornerstone of treatment for opioid use disorder, is it's different than other substance use disorders, right? Like we don't have an FDA approved med for stimulant use disorder yet, unfortunately. But we have these incredibly effective medications for opioid use disorder that have a big effect size. They're reliable, they're safe, they're effective, and that's why we're talking about today. But it's also worthwhile considering what are the other components of treatment and offering those as a menu of options to our patients, that being psychosocial interventions, recovery supports, and harm reduction interventions. So within that context, let's think about the gap. So we know these medications work. We'll talk a little bit more about the evidence, but this is kind of a recent analysis of just how big that treatment gap is. So this looks at the National Survey of Drug Use and Health, which is a household survey trying to assess the epidemiology of substance use or mental health concerns in our country, including substance use disorders. And if you go top to bottom, you'll see that first dotted line there is the number of individuals estimated to have opioid use disorder. And the reason is because like a household survey isn't the best way of understanding the burden of a really stigmatized illness, and it also doesn't access people like who are incarcerated. So that it's the next line down, the like dash line, is the prevalence based on the National Survey of Drug Use and Health, which is about a little short of 2.5 million people living with opioid use disorder in the United States. So that's one estimate. The one above it is probably what it is, and then the very bottom line, you'll see how many individuals are offered medications. And that line has an increasing slope, which is good news. We're getting more medications out there, but still not far short of where we need it to be to try to put a dent in this death crisis and help people get their lives back. So addiction and its treatment do discriminate. So within that last graph, that big gap, it's not felt equally across populations. And I think we often say that like addiction doesn't discriminate. And while it's true that substance use disorders are prevalent in every demographic, the risk factors for developing an addiction and then the damage related to that addiction, including overdose death, are not equally distributed. And so two things here. So right in the middle there, you'll see a figure from the CDC, which shows disproportionate effects of this third wave of the opioid overdose epidemic. So this is synthetic fentanyls, and the increase in mortality associated with those. And there's an 18-fold increase among Black communities, 12-fold increase among Hispanic, 9-fold increase among non-Hispanic whites. So yes, there's this rising overdose death crisis. It's not felt equally. It's important as we're thinking about these medications. We're talking about pharmacotherapy today. When we're counseling patients, we need to recognize the risk factors for patients not having access to these meds. On the bottom is another kind of recent geospatial analysis that's looking at the association of racial and ethnic segregation with treatment capacity. And we're in Austin, and Interstate 35 divides the east and west parts of this city, and the legacy of those segregationist policies are still alive and well in people's access to healthcare. What this, and I imagine other people listening are in similar places. I'm from Katy, Texas. There's still tracks there. And on one side of the tracks, there's barely running water. And on the other side of the tracks, it's a community that's more and more affluent. I mean, segregation is very well and alive in Texas. And what this looked at is the effect of segregation on access to medications for opioid use disorder. And what it found was in white predominant communities, buprenorphine, so the less restrictive of the between buprenorphine and methadone, is widely available. And in Black and Latinx communities, methadone is much more available. And the model of treatment for methadone is much more restrictive. And that has a history that's built on race and racism. So we need to have an eye towards equity when we're thinking about medications for opioid use disorder. So here's how they work. So this is a figure from the Pew Charitable Trust, and what it shows is on the top, opioid receptors represented as kind of like an empty cup, if you will, and we all have opioid receptors all throughout our body. One way to think about them, it's like a node in a system that sends a signal to the brain and other parts of the body when it's that cup with that receptor is spoken to by opioids. So the medicines are arrayed across the bottom. So if you look on your left, methadone is the first medicine we'll talk about. So that's a full agonist. And whenever it's speaking to that opioid receptor, it's totally filling the cup. So it's a full agonist. Next is buprenorphine, a partial agonist that also goes into the cup. So it does engage the opioid receptor, and it sends opioid signals to the brain and spinal cord. And, so that means pain. It can signal pain relief. It can signal a sense of well-being. It can, and it sends a wide array of different messages to different organs in the body, causing constipation and kind of a suppression of the adrenergic system. There's a bunch of different effects, but the opioid receptor, this is the way to think about it. Methadone totally fills it up. Buprenorphine fills it up, but it's not totally full. It only sends a partial signal. And then naltrexone is like taking a coaster and putting it on top of the cup and blocking anything else from getting in. It is a blocker or an antagonist. Here's another representation. So this is like the physiology perspective. So on the y-axis going up is opioid effect, and x-axis from left to right is increasing dose. And so if you have a full agonist like methadone, the more you give, the more effect you have. If you have a partial agonist like buprenorphine, you hit a ceiling effect, or you keep giving more, but it doesn't have more effect. It doesn't speak as loudly anymore to that opioid receptor. And then on the bottom, you have naloxone, which is an antagonist. And we'll return to this a couple times. So let's start with methadone. So first line therapy, it's a full agonist. It treats withdrawal and reduces cravings. And it comes in an oral formulation, can be started in the hospital. The outpatient administration of methadone is restricted to opioid treatment programs in the United States, which is the main thing everybody ought to walk away knowing, which is like, there's a medicine, like, does this molecule work for this patient or not? But then there's also the system of care, and the system of care for methadone is OTPs, which can be inflexible and require a lot of our patients to engage with this medicine. When we're starting it, there's no washout period required, so you don't have to wait. You can start methadone before somebody goes into withdrawal. We usually start it in early withdrawal, but day one is less complicated with methadone than it is with the other two medicines. Doses that are effective are typically 80 to 120 milligrams, and their adverse effects, which we'll talk about more on the next slide. It's the first line treatment in pregnancy. In terms of the evidence base, there is not, in all of medicine, there is not an intervention with a bigger bench, a deeper bench than methadone. I mean, it's been studied a lot since its rollout in the US in the late 60s, and it's over and over shows to reduce opioid overdose and all-cause mortality. And a bunch of other health outcomes have been looked at. This helps people get their lives back when they're able to access this medicine. This is a recent, this is from the NIDA website, showing again a lot of well-done studies. When people are on methadone, they're less likely to be taking opioids and more likely to be getting their lives back. Clinical considerations, this is more for the prescriber side of things. So On the figure there, what you'll see is like, that's what it takes to get methadone to what we call a steady state, right? So it is a long-acting medicine with a variable half-life. And so the x-axis there is over days. This medicine acts over days. And the next thing to know about is the risk of QTC prolongation. And I think, for non-prescribing team members, basically like, if you're talking to a client, if they have a history of heart problems themselves or a family member with heart problems, just make sure you talk to your doctor before you start this medicine. This is a rare but serious side effect that there we go. We got lights back. Sorry, gang. All right, that was the motion sensor. There's a lot of drug-drug interactions to be aware of. Because it's a full agonist, other sedatives are very risky with methadone, and that is different to buprenorphine, which has that ceiling effect. So a lot of caution is needed if patients are taking other sedatives. The first 2 weeks are the riskiest time for methadone, so you don't need a washout. So day one is less complicated, but if you look at that graph, right, it's taking 10 days here to get close to a steady state concentration. And those first 2 weeks are, it's better to be on methadone than to be on nothing, exposed to the toxic fentanyl supply. But if you look at a total treatment course of methadone, the first 2 weeks and really the first 4 weeks are the riskiest because it takes so long to get to the right dose. And people are presenting to care. Typically, it can be very chaotic and they have a lot of things going on in their lives. So for the whole team, I hope what you walk away with is people need a lot of support up front. This first month on methadone is a high risk time and people need a lot of support and harm reduction counseling around using safely if they return to use. I think, one way to think about methadone, it's really structured, and it's hard to know until you really get in with a patient about which side, if that structure is going to benefit them or not. So on the one hand, directly observed dosing and required counseling, that structure can be really helpful for people getting their lives back. And on the other hand, it's a series of barriers that can be insurmountable, especially if people have transportation barriers and medical issues that they have to attend to. So that's some stuff about methadone. Buprenorphine, also first-line therapy. It's a partial agonist, which we've talked about. It treats withdrawal and reduces cravings. In terms of its route, it's usually sublingual. There's also subcutaneous and dermal formulations, which are relatively new and exciting. It's commonly prescribed in a combo product that's buprenorphine and naloxone, but not all naloxone is created equally. And particularly in the sublingual formulation, that naloxone is thought to be inert. So it's not supposed to get in the system and cause problems. Whether or not that's true is a conversation for another day. But the thing to know is like that naloxone is not getting into people's system, we think, when they're taking it as prescribed. The reason it's there is because the federal government required it to deter injection drug use, and it might do that for people. If you inject it, then that naloxone becomes active and makes you really sick really fast is the idea. Where can you get buprenorphine? It's okay to start in the hospital and can be continued primary care, especially settings, OTPs. It does still require this X waiver, which is a burden that stops people from prescribing, but it's less burdensome now than it was like last year. There is a washout period required to avoid precipitated withdrawal. We'll talk more about that. Day one for bup is really hard, and patients need a ton of support on day one. Doses greater than 16 are most effective. There is a ceiling effect on respiratory depression. It's first line in pregnancy along with methadone, and it also has a very extensive evidence base showing decrease in overdose and all-cause mortality, among other health benefits. So some of the evidence, this is a randomized control trial from 20 years ago, showing individuals who were treated with buprenorphine had a 75% retention rate in treatment with negative urine toxicologies. Nobody died a year out, and the control group, everybody was out of treatment within 2 months, and 20% of people died. And so this is, and there's a lot of other studies showing similar things. Buprenorphine saves lives. Clinical considerations. So that first day, what we're trying to do is avoid precipitated withdrawal. And here's our figure again with the full agonist, partial agonist. So the way I talk to patients about this is, whether it's methadone or heroin or oxycodone, whatever's in your system needs time to come out, and that curve starts to curve down and drop below the level of opioid effect you get with buprenorphine. And that way, when you start the buprenorphine, it's experienced as an improvement, as an overall increase in the opioid effect in somebody's system so they can feel normal again. And if you started early, what you're going to do is you jam on the brakes and you drop down from a state of opioid effect down to that ceiling. And that is experienced as severe precipitated withdrawal. It's really important the whole treatment team know about this, because patients often think they're allergic to the medicine because their experience was just so miserable when they took it too early for whatever reason, and that with the right kind of counseling and support that can be avoided and people can safely be brought on the medicine. We often use the CAL score in patient settings to help with that. Because it is an agonist, there also needs to be caution when people are using sedatives. So you'll see here, this is the SHOUT team's induction protocol or initiation protocol. When you're starting bupe, you really got to be careful and thoughtful with your patients. It can be done safely at home with the right counseling. That's why day one's so tough. And you'll see a couple pictures of sublingual dosing. It's really important. Administration is key for buprenorphine, since the only way it gets into your body with the sublingual tabs is under your tongue or across your cheek. After you swallow it, there's very little to no absorption. But there are other options like the dermal implants, which fell off the slide. I'm sorry. And then what you see there, that's Sublocade or subcutaneous bupe, which is a once monthly injection. Now we get to our final medication for opioid use disorders. This is extended release naltrexone, or the trade name Vivitrol, which is second line for opioid use disorder, but is first line treatment for alcohol use disorder. It's the blocker, so the opioid receptor antagonist. Whether or not it reduces cravings is controversial. It doesn't have the same effect as buprenorphine or methadone, but because for some people it does have a reduction in cravings, but not for all. It's so there's oral formulation, intramuscular. Intramuscular is by far preferred for opioid use disorder. Typically, we don't use the oral formulation because in order to start this medicine, you have to have no opioid dependence or tolerance. And if you're on pills and you stop taking your naltrexone on Friday, return to use Saturday, you have very little protection or very high risk of opioid overdoses. So the pill is not preferred. It can be started in a wide variety of settings. The biggest challenge with naltrexone is the washout period. So we're talking 7 to 10 days of withdrawal that needs to be supported without opioid agonists for somebody to safely start naltrexone, which is the big barrier to starting this medicine. Because there's a loss of tolerance, there's a risk of overdose if the medicine is delayed or stopped. There's some injection site reactions, a risk of liver issues, and some people have mood disturbances associated with naltrexone. There's insufficient data in pregnancy, and then the evidence base, the reason it's second line is that naltrexone has not yet been shown to reduce opioid overdose or mortality, all-cause mortality. It's a newer medicine. Those studies could come, but at this point, it is not shown to be nearly as effective as the other medicines. But it can really help, and it's an option that our patients really should have because it has been shown to increase retention and treatment and lower illicit opioid use. Don't start in withdrawal. Can't start in withdrawal. Got to get people all the way through, and we have often we use naloxone challenges to make sure somebody is not dependent on opioids before starting it, because that is a 30 days of an antagonist in somebody's system if you start it too early, which drops you all the way down to the bottom of the graph on your right. It can complicate pain management. So for our patients, especially in general medical settings who might have surgeries coming up or have other issues that might require opioid pain medicine, it's much more challenging when somebody's on Vivitrol. This second last slide about treatment options comes from a visit I had with a patient last week who was having side effects with bupe and was like, what are my other options? I've tried methadone, I couldn't make it there every day. He doesn't have access to Vivitrol. And I just told him, like, look, there's other options in other parts of the world. It's not legal in the United States yet, but these are evidence-based approaches. So injectable opioid agonist therapy is increasingly used, especially in Canada, where it's not the standard of care first line, but it is an option for patients with treatment refractory opioid use disorder to do injectable diacetylmorphine, which is heroin, or hydromorphone in a controlled, safe setting so that people aren't exposed to an unpredictable drug supply, and their opioid system is stabilized by a knowable, anticipatable dose of an opioid. Slow release oral morphine or SRAM is second line treatment in the biggest Canadian guideline. it's the same principle. Those are some of the trials that have shown the effectiveness of medicine. There's been a lot of media attention appropriately to innovative interventions to help stem the tide of opioid deaths. Safe supply is one of those. Safe supply is getting opioids or benzodiazepines or stimulants to patients in a structured clinical setting so that they're not exposed to toxic drug supply in a way that's safe, effective, and reduces the risk of diversion. So this is a very clinical approach. It's very innovative. It's not done in many places, but that is different than drug legalization or regulation of the drug supply. And so some of the, like in the New York Times and then the Texas Tribune, they weren't really clear the difference between these 4 interventions. They are different, and the clinicians and advocates who are bringing these online have an eye towards diversion. It's not just willy-nilly. This is a thoughtful approach to how to address like a really challenging clinical scenario. Those are some of the differences there. Narcan. So anybody, if you're thinking about any of these meds, they should definitely have access to Narcan along with these other groups. The last note is about detox. So medically assisted withdrawal doesn't work well, and we often have patients who don't want to be on medications. And I think approach here is to continue long-term addiction treatment, offer the menu of options of other things that are available, let them know this is what the evidence shows. And if your goal is to get your life back, probably your best shot is to be on one of these medicines, but we're going to keep working with you towards your health goals regardless. So how do you decide between the different options? I think taking the principles of shared decision-making and tailoring that decision based on a patient's preferences, needs, and values puts in as much as you can, put them in the driver's seat and then advocate to get them to that treatment option is the right approach here. And you use those principles of MI, right? So, starting out saying, can you tell me, what do you think about medications to help with opioid problems? Oh, it sounds like you're interested in learning more. You have some friends who have really benefited and others have had negative experiences. And then using reflection, say, on the one hand, you're hesitant to go to a methadone clinic every day. And what that means, but on the other hand, you're ready to make a big change in your life and methadone might help you. And then to have summarizing statements to help move towards a plan. So I think MI can really help us as in the room while we're working with patients to make these decisions. This is another reference slide that describes a lot of what we talked about. And then back to learning objectives. So hopefully folks have a better understanding of the mechanism of action for these meds. We've talked a little bit about the evidence, and I hope we're all a little closer to having a good process for doing shared decision-making around these medications with our patients. All right. Any questions? Just checking the chat game.
There's one question from Xiao Chin.
Oh, I see. Good. Okay, so great question. So if somebody is in acute fulminant liver failure, I'd think about starting buprenorphine at a slightly lower dose. That's the relevant clinical scenario. There used to be a lot more concern about starting buprenorphine in people with liver issues, especially like people who drink or have hepatitis C concurrently. But there's a lot less concern now because for a lot of reasons. But compensated cirrhosis, I usually don't change the dose. Decompensated cirrhosis, start at lower dose. Fulminant liver failures, people are often in the hospital or in the ICU under close observation. If they have active opioid use disorder, the relative risk of being discharged off of medicine versus starting on buprenorphine is like so different, but you might just start at a lower dose. Does that answer the question? If it doesn't, let me know. Oh, good. This is great, guys. Okay, so first question, monoproduct, butte monoproduct recommended for liver dysfunction in pregnancy. Sometimes this is harder to get due to pharmacy availability or insurance wanting a prior auth. Is there really a problem using a combo product? So two different scenarios, liver dysfunction, pregnancy. So liver dysfunction, again, this is an naloxone component that we're worried about. a reduction in transformation and clearance from the liver and a risk of hepatotoxicity, which is not borne out in trials. So to give somebody sense, like naltrexone, not naloxone, but naltrexone is used in people with cirrhosis from primary biliary colon, from PBC. I hope I'm saying that right. And there's a significant clinical experience with this that has lowered our overall concern about exposure to naltrexone, naloxone for people with liver issues. So I'm not worried about liver. Buprenorphine monoproduct in pregnancy is typically still the first line. There are some great counseling resources from the Boston Medical Center for talking to pregnant people about the choice between buprenorphine and buprenorphine naloxone. I can tell you both are used as a first line now, because again, those concerns for teratogenicity from the naloxone were not borne out. And I find the reference for folks from BMC for that. So combo products are used in pregnancy now as part of first line. When is too early to start bupe? How long is the detox washout period? It's different based on the opioid you're using. So if somebody's using a short-acting opioid, that's kind of a longer conversation. I don't want to take up too much time, and I know we're going to get to the case.
Maybe we can address Kelsey and Phil's questions and then move on to our next portion.
Sweet. And Kelsey's question was, how long a deal? Okay, so if it's really long acting, like methadone is complicated, and there's different answers. We typically wait 48 to 72 hours for a standard induction for a washout with a lot of support after methadone dose has been dropped over time. But there are some more innovative approaches using things like low dose inductions or microdose inductions for methadone for like the most long acting. For really short acting, it's typically like 12 hours, but it's really based on symptoms. Different patients have different experiences of withdrawal. So the safety is of the washout period is based on symptoms. That's what we use that CAL score for in inpatient settings. But I think in clinic, we usually tell people if you can wait 12 to 16 hours, if you're using some of the shorter acting ones, like heroin's a little longer, but heroin or oxycodone, that's ideal. Fentanyl is complicated. And we're going to have some upcoming webinars on transitioning from methadone, bupe back and forth, and fentanyl starts. Fentanyl is really challenged buprenorphine starts. I mean, it's worthwhile learning more about it because our patients are encountering challenges. Phil dropped some knowledge with working peers. I find it super valuable to express that there are no expectations when using MI, as many with lived experience with substances may consider MI as manipulative or directional. Do medical professionals? Oh, super deep. Yes, I have an agenda, so I'm a person, right? And it is often challenging to enter into that encounter with the kind of honesty and forthrightness that coaches often do. Because as a doctor, I just have an agenda, and trying to be honest about that is important. And then being thoughtful about when to use MI. So there's parts of a patient encounter where I'm not using MI and say like, I'm not, I'm going to make a recommendation now. And I try to do ask, tell, ask, it would be okay if I tell you what I know about the safety of this medicine versus that medicine. But I think you're right, we should have some pause about when MI is appropriate and how we enter into those conversations. Phil, that's super deep, man. I hope that's helpful. Anybody else have any takes on MI in this scenario?
With that note, I think we'll move on to our next portion of our session, but please keep the questions coming. This has been amazing, and our hub here will do their best to answer these questions. Thank you so much, Dr. Weems. This was a great review of the pharmacology. So with that, we'll move on to announcements. Carly, if you could please bring up the announcements. Thank you so much. Be Well Texas is a welcoming environment with caring professionals who are ready to help people start or continue their journey towards recovery. Be Well Texas is committed to expanding equitable access to compassionate, evidence-based treatment and care for SUD throughout Texas. Next slide. The Be Well Texas Clinic offers high-quality treatment for addiction recovery at low, no-pay or self-pay insurance to all patients, so they are accepted regardless of their payment ability. Next slide. If you need technical assistance beyond what is offered in ICO sessions, please complete an online request form and we will be happy to assist you. This is available on our website at cstat.utisca.edu. Next slide. Please join us for next month for Shout Echo. We will be discussing hospital standards of care for SUD treatments. And next slide. A quick reminder, due to Thanksgiving, we will be having Systems and Sustainability Echo on Monday, November 28th. This is the Monday after the Thanksgiving weekend. We will be sending out reminders through email, so please watch out for them. We hope to see you there. And with that, we will now move on to the case presentation. Once Carly shares the case, Dr. Handayan, please take it away.
Right. So my name is Dr. Daniel Hendain. I'm a fellow over here in Memphis, Tennessee. I guess a little overview of our program. We are currently 5 fellows. We cover at the moment 11 hospitals in the Baptist Memorial Health System, primarily through telemedicine. Our main hospital here in Memphis is in East Memphis. It's a 700 plus bed facility and multiple residency programs. But all the outlying hospitals are, whether in Tennessee or in Mississippi. We are soon to be in multiple hospitals in Arkansas through the Baptist health systems. So currently, the consult service has been open since end of 2019. Dr. Sean Ham is a program coordinator. He created the program with who was the ex-dean of the University of Tennessee Health Science System. And initially, the program was through the University of Tennessee, which was absorbed by the Baptist program. And the program is funded by a HRSA grant. So it is funded for a total of 5 years, 5 fellows for a total of 5 years. So it's a fairly large service area with multiple hospitals in multiple regions. The program is partnered with a national substance use treatment company called Vertava Health. So primarily that's where a lot of our resources come from. Our outpatient treatment clinic is located on the outskirts of Memphis. And there's another clinic in more rural part of Tennessee, out in Jackson, Tennessee, where we see patients in the outpatient setting through telehealth as well. So primarily through Vertava, they offer us a lot of resources in terms of discharge planning, in terms of placement, if a patient does want to go into inpatient treatment or detox or residential treatment as well. And so currently, our number of consults we had in the last month were a total of 85. And that's including 11 different hospitals through the Baptist Memorial Health System. So we're looking to increase, I guess, our number of consults, increase the screening for patients with substance use disorder within the hospital system. As the numbers pretty much around the country, I would say, especially here in Memphis, I would say maybe one in every 3 patients coming into the hospital, or 1 to every 4 suffer from substance use disorder. So we are working on finding ways to screen patients in the ER once they're on the floor, working with nursing staff, LVNs, trying to get champions who would be willing to help screen patients. We're trying to run a pilot program on one of the floors in the Baptist hospital system here in Memphis. And currently we're trying to meet with hospital administrators, essentially to kind of get out the word of the consult service. Many hospitals don't use our consult service, if we can say it that way, as much as other hospitals. There are hospitals in kind of more rural areas of Tennessee who we get consulted very, very rarely on. So we're pushing to get educate those hospital systems administrators and the staff on our consult service, since those are primarily telehealth. We've been talking we just had a meeting with Dr. Marlene Martin up at UCSF General Hospital up there about their consult service. Their consult service started around the same time ours did, and they've been working very heavily with administration and the nursing staff to educate them on screening, on stigma, and basically essentially getting individuals to talk about recovery. That's how we got one of our ideas for and working with LVNs and the nursing staff. But it's been a process. We just started working with recovery coaches this past year. So we have 2 recovery coaches. They primarily go to 3 rural hospitals, but they've been very useful in following up with patients who are interested in seeking treatment. So they are employed by Vertava Health, and essentially they are on call as well, 24 hours a day, 7 days a week. We have a 24-hour-a-day placement line as well. So in all, we're trying to cover a very large hospital system, a very large area, which I think we are doing better now than before with the recovery coaches and having meeting with the hospital stakeholders and administrators. That has increased our consults, but we're still looking on ways to increase awareness of our consult system here in the Baptist Memorial Health System. So that's kind of one of our goals, trying to reach more patients and screening them, and for kind of get them into treatment in our company. So that's a little overview. If anybody has any questions or comments.
Thanks, Dr. Hendan, for bringing this case forward. It's really interesting. And congratulations on all the work you're already doing to try to increase the visibility of your services to, so many different hospitals. I was really glad to hear you say that you're working with a couple of nurse champions on certain floors to screen patients in the ED for any evidence of substance use disorders. That was going to be one of my questions. Is there a role for a model where you chart review or screen patients beforehand and reach out to the hospitalist taking care of them to offer your services instead of like waiting around to be consulted? We have kind of a similar service here at Dell called the Proactive Behavioral Health Service that screens all the admitted patients to our hospital every day. And they use certain screening criteria. So anyone who pops up with a high alert flag, anyone who has a positive alcohol level on admission, or a positive urine drug screen on admission, those things don't take a long time to check. and they get added to the list. And the proactive behavioral health team goes and sees the patient and sees what they can offer them in terms of recovery. So really glad to hear that you have kind of you're trying to pilot that kind of screening system already, because a lot of people, as you know, could benefit from these services. The other thing I wanted to say, even if the consult volume right now is, lower than expected, sometimes finding like that one good story and publicizing it can be pretty helpful. So if you had a patient, you identified them as having substance use disorder, plugged them into resources or rehab, started them on, medications, and it was basically a good success story. That's a really good thing to kind of publicize rather than just saying, hey, we're an addiction consult service, call us. I think that's a good way to get the word out. And then currently, how are you consulted? Do people call you on the phone? Do they, put in an order or email you, or how do they actually engage your services?
Yes, thank you. Those are all very great. Great ideas. Our consult service, primarily we're consulted. It's an order that's placed in the system either by, I think it's mostly physician-led, hospitalist-led consult orders. We usually get called by the HUC or the nurse to our consult line, and we essentially see the patient depending on, like I said, wherever they're at. If it's here in Memphis, the hospital is about at most 30 minutes away from our clinics. So we go there and round on patients in the hospital there. Try to keep open communication with the nurses and the attendings. Just try to keep them in the loop and also keep us in the loop of knowing when they're getting discharged, so we know exactly how much time we have. So a lot of times, like Dr. Weems was saying, we've been trialing, because there's so much fentanyl out here, a microdosing, kind of using that Bernese method. So someone's here for at least 5 days. We go ahead and try that. So that's been very helpful and important to keeping in contact with the discharge planners, social workers. But yeah, primarily the consults come in through them, and it has to be placed typically by a physician. Sometimes there were a few cases where it was placed by the social worker, and the social worker had talked with the patient and had asked the patient if they were looking for any kind of recovery treatment services, and they said yes, and the social worker knew about our consult service, and she ended up calling us.
Okay. If it is a order, one thing that we used to have is whenever we had a patient admitted in alcohol withdrawal, there'd be like an alcohol withdrawal order set. The consult behavioral health order was at the bottom of that order set. So I wonder if you can work with IT to get that order as a part of an order set for a patient who's admitted to the hospital in withdrawal or something like that. So to get people thinking about how you can help them after they are treated for their acute withdrawal. That's one. And I also really like the fact that, you're trying to recruit some champions. Like it seems like a lot of hospitals or most of your consults are coming from like a few hospitals and, a few physicians, and engaging those physicians, the ones who have found the most use from your service, in order to kind of spread the word, I think also is good, having those people on your side, because this is a team sport in the end, and having people who are interested in using your services and have benefit from your services, good to get on your side. Also really glad to hear about peer recovery coaches and engaging peer recovery coaches in your treatment model. That's wonderful. I hope you continue doing that. I'll stop talking for a sec. Does anyone else have any ideas or comments about Dr. Hundayan's case?
I see a question in the chat. What screening tool do your hospitals use to get referrals?
It's pretty much just the attending. So there'd be a surgeon or the hospitalist or the residents. Essentially, if they feel that our consult service is needed, then they go ahead and just place the order for our consult. So we don't have any screening tools currently in place. It's essentially if the provider feels that our services would be warranted or needed.
I think even defining inclusion criteria, so to speak, for your service might be helpful as well. So instead of saying, if you have a patient who has an addiction, consult us, it's like, do they have a positive alcohol level? Do they have, psychosocial disorders that involve psychotropic medications? Do they, have opioids on their MAR? And so trying to, and those aren't perfect for capturing people with actual use disorders, but even to get people thinking automatically about what you have to offer when they have a patient with these kind of features might be helpful.
Any other thoughts from the learning community? If you've had, and I see some notes from some answers from Dr. Weems regarding the didactics. Thank you, Dr. Weems. But opening up to the learning community. So there's a question here. Do you incorporate telehealth in your consults?
Yeah, so most of our consults, we see them through telemedicine just because they're everywhere. We're soon to be in 16 hospitals. Right now we're 11 hospitals throughout multiple parts of the state and in Mississippi as well. So we use a telehealth service called VidYO that essentially the nurses help us out with, and for any kind of consults, we see them through the video chat system, and that's been very, very useful in terms of speaking with individuals, kind of get that face-to-face contact with them. We've also had to do it over the phone because a lot of times the VidYO service or the iPads are down, and it's not the same as when you have at least through the video service. But we've actually reached a lot of patients and got them into treatment through the consult service and through the telehealth consult service as well.
That's awesome. And how involved are your ED physicians in screening, consulting, starting meds at or before admission?
Yes, that goes back what Dr. Ramesh was saying. We have, in some of the ERs, they're really good about consulting us. So there's certain ER docs who consult us on essentially every patient that comes in, whether being withdrawals from alcohol or whether or not they had urine drug screen that was positive, and the nurse went in there and asked them if they needed our services, and they said yes. And there are some other hospitals that we never hear from them that often, I would say. So we try to speak with the doctors who are really helping us out, try to help them out so that the word gets out that we're doing, we're helping them out as well, especially with placement discharge planning. We've had patients that we've sent home with a bridge of Suboxone to come see us in the clinic afterwards, and they're happy with that. So, you know, I would say there's a lot to be done in that area, but we're just going to continue educating and spreading our consult service, spreading the word of it.
Thank you so much. This has been a great discussion, and in the interest of time, I would request Dr. Ramesh to provide a few recommendations. And yeah.
All right. Again, thanks, Dr. Hendayan, for bringing this case forward. So this was a really great discussion about how to spread the word and build capacity to see patients for an addiction consult service that's primarily serving 16 hospitals in a large land area. And so some of the things we discussed is screening patients proactively through their charts to see who might benefit, and seeing them proactively before even waiting for a consult, utilizing the electronic medical record to put the order for the consult in like order sets for alcohol withdrawal, things like that, and recruiting champions that do use your service a lot to continue to help spread the word and educate people, especially your ED providers and then the hospitalists who use your service a lot. And then expanding your peer recovery services and your stigma education to make sure that people understand what value you have to provide. So sounds like you're doing all the right things. Great case. Thank you for bringing it forward, and hope everyone had a good time.
Thank you so much, Dr. Ramesh. Thank you, everybody, for joining today's session. This was a wonderful discussion. As a reminder, to earn CME and CNE credits, please complete a post-session survey using the link in the chat. We look forward to seeing you at our next session on Thursday, November 17th. Have a wonderful rest of your day. Thank you so much.